right, thank you everyone. And now it is my pleasure to introduce our next speaker, Dr. David Spiegel, who will be covering the topic of orthopedic insights for everyday living. Dr. Spiegel works as a pediatric orthopedic surgeon at the Children's Hospital of Philadelphia, specializing in neuromuscular diseases, trauma, and spinal deformities. He is he is professor of orthopedic surgery at the Perelman School of Medicine at the University of Pennsylvania, a Penn Center for Global Health scholar, and he holds the Dennis S. Drummond Endowed Chair in Pediatric Orthopedics. He has served as an honorary consultant in orthopedics and rehabilitation at the Hospital and Rehabilitation Center for Disabled Children in Benepa, Nepal, for nearly 3 decades, and is an honorary professor at the University of Basra and the University of Baghdad, Iraq. He was awarded the President's Call to Service Award in 2006, the Humanitarian Award from the Pediatric Orthopedic Society of North America in 2013, the Walter P. Blount Humanitarian Award from the Scoliosis Research Society in 2016, and the Humanitarian Award from the American Academy of Orthopedic Surgeons in 2017. He has served as a consultant for the World Health Organization in Mongolia and Somalia. He has delivered more than 450 invited lectures, mostly at the international venues, including Nepal, Iran, Iraq, China, Pakistan, Tanzania, Mongolia, and Somalia. He has also co-edited a textbook entitled Global Orthopedics, Caring for Musculoskeletal Conditions and Injuries in Austere Settings. Dr. Spiegel, that is quite the bio you have there. So thank you so much for taking the time to join us today. And we look forward to hearing from you. And I will turn the time over to you now.
Great, thanks. Can you hear me?
We can hear you.
Okay, so now the only thing is, now I'm stressing out over, okay, let's see. Now, are you able to see the first slide?
Yep, I can
Oh,
see it.
all right, so that's great. So again, thanks for the opportunity to speak. Let me just make sure that this is forwarding, and how am I going to do that? Okay, there we go. Okay, so orthopedic insights for everyday living. I guess it's a very general topic, and I didn't want to make it too scientific. So it's more, I guess I'd say, food for thought than anything else. And I don't think there is a huge volume of science in this subject area, at least for the musculoskeletal management. So to me, it becomes an issue of shared decision making, working with families, and working in a multidisciplinary setting to try and come up with a logical goals and a path to achieving those goals, at least as far as musculoskeletal care is. So let's see. Okay, so the 3 issues that I was asked to discuss are contractures, the hips, and the spine. And then with regard to mobility, lung function, and the activities of daily living. So I think all of you are quite aware that there are a number of outstanding and treatments that are available that are really changing the course of the disease. So a lot of the old algorithms or thought processes for managing patients with SMA, at least musculoskeletal wise, have changed quite a bit. And I think I just look at it as each patient is their own control. They're all individuals, and we just sort of come up with the best solutions to suit the individual patient. But for the rest of the talk today, just try to talk about some general things that make sense. So what are the take-home messages I came up with? Well, the natural history is obviously altered by the disease-modifying treatments, multidisciplinary, focus on function. I mean, I think if we just tried to address every physical finding or impairment that patients have, that would be a whole lot of work, much of which might be unnecessary. So there needs to be some functional goal, or at least in a reactive sense, treating symptoms such as pain and so on. So I think role for the type of orthopedic surgical treatment that we offer is being redefined. And we'll discuss both proactive and reactive strategies for contractures. For the hip, traditionally it's been reactive, but in light of changes in the natural history of the underlying disease, I think that we may be more proactive in the future. And then with the spine, orthotic support can be helpful in many cases. There are younger patients who develop a progressive deformity of the spine that requires us, should we require a surgical treatment, to do something called growth sparing, which allows for growth of the lungs and the trunk. And then definitive spinal fusion is appropriate for some if the curves are progressive and they've reached a certain degree of skeletal maturity. So those are the messages. So let's start off with the contractures, which, as you well know, are loss of movement or loss of motion at a joint. And of course, this is partly due to weakness, but also due to the effects of positioning. Particularly, I mean, for example, if someone is sitting in a wheelchair a, a sizable portion of their day and the knees are flexed at 90 degrees and they develop a contracture, well, that makes sense. And just like it makes sense that if one straightens the contracture, that if they go back to spending a sizable amount of their time in the wheelchair, it's likely that the contracture will recur. Contractures can involve fixed shortening of a muscle or the muscle tendon unit, can also involve replacement of muscle tissue by fibrofatty tissue or by scar tissue. And then the contracture or the loss of motion can also occur at the level of the joint. So not directly related to the muscle, but in fact related to those soft tissues that hold the joint together. So this will be of interest to you, particularly when we discuss the contractures of the knee joint. So without going into too much detail, the most common contractures are what we would call a flexion contracture, or the inability to extend the joint. And this can occur at the hip, as shown in the upper right, at the knee, the picture in the middle, and then at the foot and ankle, the equinus type contractures there. And you can see some of the statistics. So these contractures are very common, and you're all familiar with them. The contractures tend to increase over time, and that makes sense too, because bones are growing, and depending on the anatomy of the musculoskeletal tissues, the bones will often result, through their growth, you can get coexisting shortening of the muscle tendon units. Um, so what are the impact? Well, I think most of the impact is well known to you, and this really falls into the domain of mobility. If a patient's walking and they develop contractures at the ankle, well, then they might lose their base of support. They may be up on their toes. If the knees become contracted and can't straighten, it's very difficult to walk for a long period of time with the knees in a flexed position. And same can be said for the hips. And then contractures at some levels are balanced by deformities at other levels to maintain an upright position. For those that are sitters, contractures can impact their positioning and ease of care in a wheelchair or other domains. There's not going to be much of an impact on the lungs from extremity contractures, obviously, but there will be an impact on activities of daily living. And the same can be stated for contractures of the upper extremities. You're all familiar with that. So what can we offer as far as the management of contractures? Well, proactively just being aware that they're common, they will occur with time. And so trying to prevent them from developing, as difficult as it is probably a good start. I tell patients all the time that I know you're working hard. We're doing all the things to try to prevent those problems, but it's a force to be reckoned with, and often we're not completely successful. But anyway, working on positioning, physical therapy, obviously. Non-operative treatment might also include serial casting and cast wedging. In the multidisciplinary clinic where I work, serial casting for knee contractures is commonly performed, as well as at the ankle. Most of you are familiar with braces and the need for using orthoses to support ambulation or to support positioning for ease of care. Something like an ankle-foot orthosis is a static device. However, for nighttime use, one can get a tensioned stretching splint for the ankle equinus or for the knee flexion contractures. And the question of when to use it and how long remains debatable, but certainly those options are available to our patients to try and prevent contractures in addition to the other things that have been mentioned. So one of the, I'm just giving an example here of the approach that one might consider for the knee flexion contractures, which are a very common thing in many neuromuscular diseases, and the same can be said for kids with SMA. And so, the magnitude can vary and the impact can vary. As we mentioned before, patients who are ambulating will find it very difficult to ambulate with the knee in a fixed position and the inability to extend. So we spoke about stretch casting. I apologize, I'm a little bit out of, my things out of sequence. So if you look in the upper right-hand picture, that's a long leg cast above the ankle. And when we're doing serial casting for the knee flexion contractures, often we'll apply the cast. The next week, we'll wedge the cast, as you can see there, and put in a little spacer and gradually get correction through that mechanism. Soft tissue lengthening and release is a surgical option that can be coupled with stretch casting or can be coupled with other types of interventions. And so that would be appropriate to consider in the circumstance where a patient was losing function and it was very important to maintain upright mobility, and having a straight knee was a critical component of that. Then, and if our non-operative measures failed, one can consider soft tissue lengthening or release, such as release of the hamstring muscles. Now, as I mentioned before, soft tissue contractures can be not only due to muscle, but due to the joint itself. And while one can surgically release the back of the knee joint, it's kind of prone to complications and very prone to relapse. So at least my practice and my training was to avoid that particular procedure. So for patients who have minor degrees of fixed flexion contracture at the knee, one of the recent strategies that orthopedic surgeons are using is something called guided growth. And I don't know if you can see my little pointer here, or look at the middle picture. There are a couple of little screws in the end of the femur bone. So these are placed, watching them on TV through a small incision that would take 1 stitch. It can be done as an outpatient. And the idea is to cause the distal part of the femur to grow asymmetrically into a little bit of extension to essentially create a small bony deformity to overcome a soft tissue deformity. This is something worthy of consideration for minor degrees of contracture, perhaps maximum of 10 to 15 degrees. And the most extreme option available to acutely get the knee straight is to realign the distal part of the femur through an osteotomy. So while I've done probably over 100 of them in patients with cerebral palsy, I haven't found the proper patient yet in the SMA population. So please understand, I'm just trying to give a slide which sort of offers a stepwise approach of what might be considered should the primary goal be to get the knee straight. And so all of these options are available and are considered often in combination to achieve that goal. But in my experience, at least in our clinic, most of the time we're just considering stretch casting occasionally with some soft tissue releases. I haven't been involved in any bony work. And then I didn't want to spend a lot of time on the foot and ankle, but at the most common thing that I've seen, at least in the population with SMA, is the equinus contracture, which is the tightness of the heel cord and the ankle, often in combination with a little bit of tightness in the muscles on the base of the foot. And that obviously leads to inability to get the foot flat and therefore inability to comfortably be braced and maintain an upright posture. So in those circumstances, it might be appropriate to do serial casting or to consider a muscle lengthening to be able to position the feet flat if that was so desired. Um, so I'll just continue on. So, okay, so now moving towards the topic of hip dysplasia and hip dislocation. So I guess when it comes to mobility, at least in my experiences with neuromuscular hip dislocations in this group of patients, often the mobility was better than in other neuromuscular diseases. And it wasn't common that uh, the displacement of the hip was a major factor with positioning or ease of care, at least that I can recall. Clearly, there'll be no issues with regard to respiratory function and activities of daily living, I guess to the extent, particularly if one hip was dislocated, that could alter your sitting position and sitting balance. Um, but as I move on, I think the story of hip displacement in the SMA population will be a little bit more clear. So historically, I think a lot of the approach to looking at the hip displacement was quite similar to that for polio. So or other forms of flaccid paralysis. So the teachings from polio from 60 to 70 years ago were that surgical interventions to relocate the hips were not particularly successful because there was no motor strength around the hips or no balance of muscles around the hips to prevent the hips from displacing once again. And so while there wasn't a whole lot of literature written on it, that fell out of favor. And my experience through early years, not the early years, the first 20 years of the career were that in general, the same philosophy was applied to patients with spinal muscular atrophy, in that the limited information available in the literature suggested that, surgical procedures had complications and they weren't that successful in being able to achieve a reduced hip that was maintained in a reduced position over the long haul. So surgery fell out of favor. And this wasn't inappropriate. Here's some of the literature available. However, so even though we're not thinking in terms of types 1, 2, or type 3, what we found, particularly in types 2 and 3 in non-ambulatory patients, was that virtually all the hips became displaced or dislocated. And our impression was that not that many of them were painful. And so therefore, being aggressive surgically with hip displacement did not seem to make sense in the overall scope of things. And the feeling was that in general, pain was not a big issue and that there were not major functional consequences. So therefore, until the recent years, the stance in most centers was reactive rather than proactive. In other words, we didn't screen for hip dysplasia and we let the natural history take its course. And then if individual patient circumstances dictated, particularly someone was ambulatory or someone was having pain, then we adopted a reactive strategy and addressed the hips from that standpoint. So here's just an example of a patient that I cared for years ago. You can see the way the hips are 2 years. Again, I hope you can see my little arrow, but 2 years to 4 years, you can see what's happening is that the femoral head is now obviously turning to bone better, but it's becoming more displaced outside the socket. The socket's becoming a little flat. And you might notice here that there's a very high angle of the head and neck of the femur relative to the shaft or to the thigh bone. And look at what's happening by 5 years and then 6 years. And now the hip is significantly subluxated. It's partially out of place, not completely out of place. So typically what we would observe, and this is what one might see in polio as well, or any type of flaccid or very weak or very low tone type situation. So then as time went forward, here we are at 10 years and then 14 years, both hips have dislocated and the hip femoral head has become irregular. But this patient is now, 18, 20 years of age and still not having any symptoms referable to their hip. But this was a different era, and I think this is the way we used to approach things. So now, how do we contextualize things in an era of the disease modifying treatments? Well, I think, we need to rethink everything. And here's one of the early papers. This came out a couple of years ago and basically suggested that hip pain was not uncommon in patients with SMA with displaced hips. Um, and in fact, it was moderate to severe in 14% of patients, and 5 of 60 required surgical intervention. So this kind of reflects more of the reactive type stance or posture to managing the hips. So, but with the disease modifying treatments and patients getting stronger, and I think you're all as thrilled as I am working in your clinics and seeing the things we've seen over the last couple of years makes us really need to rethink the management of the hips. So I can tell you how we're approaching it, at least in our place, and then as food for thought. And so I think we do feel that it's important to keep a close eye on the hips. So we set up a surveillance system for that, and that under the proper or under the correct circumstances, we might be proactive in trying to prevent the hips from displacing, particularly in patients who are making functional gains, particularly patients who are getting stronger and are upright and ambulating. And I don't think I can be prescriptive at this point in time because, again, we're all learning as all this evolves. But I'm certainly thinking about being more active in managing these. So, what are options for treatment of the hips? Well, I guess it depends on a number of different variables in addition to that which I had just mentioned before. So screening in the patient population with cerebral palsy, screening has always been based on something called the migration percentage, which is shown here in this X-ray on your right. And it's essentially the percentage of this round ball or the epiphysis that goes outside the edge of the socket. So it's A over B. Now, that in this I'm showing here is a hip surveillance program for cerebral palsy. It's been done at the national level. This is the American Academy of Cerebral Palsy and Developmental Medicine. So long, make a long story short, at least in our clinic, we adapted this this hip surveillance care pathway to the patient population that we have with SMA. And so that's been something over the last year or two. So we're monitoring that as well. So what are the at least options worthy of discussion for management of the hips? Well, is there a way to prevent or stop the displacement from occurring? That's why we're doing surveillance. Number two, if we can't prevent it from happening, then our options would include something we can call reconstructive. In other words, we're going to surgically address the abnormal bony anatomy to keep the hip back in, or to put the hip back in place and keep it there. And the last option would be that of a salvage treatment. And this algorithm or thought process is essentially the same as that in the cerebral palsy population. So salvage means that there's been too much damage to the femoral head to make it make sense to put it back into place. This is a patient with arthritis or chronic pain in the hip, and we don't think that putting it back in would be a wise choice for that patient. So those are the kind of the three options. And then I thought I'd just talk briefly about those three. Okay, so the first is I'm mentioning this because it has taken on a lot of attention in the group of patients with cerebral palsy, and it's called guided growth. So what I'm showing you here is putting a screw through a small incision using the TV set into the hip. Look on your right side, upper and lower, and you'll see, oh my goodness, well, In this case, we've injected some dye into the hip joint, and you can actually see how big the ball is, right? On a plain x-ray, you only see this smaller part of the ball. So we inject dye into the hip to make sure that the screw is long enough past the growth plate, but not into the joint. But the point is that the idea of the screw is to try to modulate the growth of the upper part of this femur bone to point downward. In other words, remember I showed you the x-ray before where gradually over the years, the, the angle between the head and the neck and then the shaft of the bone kept increasing and getting near vertical. The idea behind this is to stop that from happening and to improve it. So pardon, I'm going to go back to that. I cut out all the slides on the literature review because I can just summarize it for you. And I think we are able to modulate growth with this strategy. It's still a work in progress to understand in cerebral palsy exactly who the proper patient is. But in general, they're younger patients, and there are patients who are at a very high risk for the hips to progressively displace. We have natural history data on that group of patients. Right now, we're essentially creating a new natural history with spinal muscular atrophy. So we're not going to be able to have really natural history data that is going to go along with the disease modifying treatments because it's simply too early. But what I would say is that on an individualized basis, this type of strategy could be discussed and potentially utilized in the SMA population in selected patients. But I can't get beyond that because I'm well aware that different people have different stances in their clinics around the country. And in the absence of, strong science at this point in time, all I would say is that I discuss this with the team, the multidisciplinary team, and the patients, and we think about it in selected patients who we think are progressively displacing, and we use it as a tool to try and prevent that from happening, recognizing that we don't have the long-term data. So I think I'm going to leave it at that, and we can answer some questions later or talk about it. But I think everyone needs to be aware of it, and it certainly will play a role at some point in the future. The question is, who exactly is the correct patient for this strategy? Now, here's so getting into the option of reconstruction, meaning the hip is coming out and we know what the natural history is, it's going to come out. And in our particular patient, that would be felt to be an undesirable outcome. And we're willing to accept doing surgery to try and keep the hip in. Well, the strategy is as shown here to realign the abnormal anatomy of the upper part of the bone. You can see the bone was cut at about this point. It was angled downward. The ball was angled downward, and then it was fixed. This metal thing is just holding it in the corrected position. And then as you look above that, you can see, I don't know again if my arrow is showing up, but you can see the piece of bone from here is put into the pelvis, and the pelvis, which had a very high angle, is brought down. So you can see that here the femoral head is more than 50% out of position and about ready to gradually dislocate. Here it's back in position. So the techniques, if whether a patient has SMA or whether a patient has another neuromuscular diagnosis, the treatment strategy for getting the hip back in position is essentially this. So anyway, I just thought that I would show that for the sake of being complete. It's not commonly performed I mean, I've done 200 if I've done one in neuromuscular patients in general, but in the SMA population, it has not been common at all. But I think in the years to come, there are going to be patients who are going to be benefited from this approach. The last approach is that of salvage, and I'm not going to spend too much time. I haven't had to do a salvage yet in a patient who's had SMA, but one opportunity for salvaging that is just removing the upper part of the femur and that's been used successfully in patients with other diagnoses. Another option in patients who bear weight is to remove the ball and realign the stick. Anyway, without spending too much time on it, let me suggest that there are numerous options available for the very rare patient who has a displaced hip, who has chronic pain, and who has arthritis. It hasn't been common in, again, in the patients who I've cared for over the years with the diagnosis we're speaking of today, I haven't had to do that surgery yet. So again, this is all I'm trying to tailor and share ideas with you because, as I mentioned so many times before, the entire natural history of the musculoskeletal system is being modified before our eyes. And so a lot of things that we haven't discussed in the past will merit discussion in the future. So the last part of the talk, and I think I'm doing okay on time, I may even end a little bit early so we can have more time for the questions and answers. Last part of the talk deals with the scoliosis, which is probably the most or one of the most common problems that has historically been treated. And in general, virtually all the patients with the so-called types 1 and 2, as described previously, would develop a scoliosis. And typically that scoliosis was an early onset scoliosis. So that mandated early care. So you're all aware scoliosis is a three-dimensional problem, although we try to measure it on plain x-rays. And the, curve progression depends on a number of variables, and it's very different in idiopathic scoliosis versus different types of neuromuscular scoliosis. In kids who have flaccid weakness or hypotonia or this type problems, who don't have the musculature to support the trunk and to support the upright positioning, the scoliosis tends to progress more rapidly than in other clinical circumstances. And I think that's part of why we see a lot of early onset scoliosis, meaning, 4, 5, 7, 8-year-old patients. The other thing that we take note of is that thoracic deformities may impact pulmonary function. On the right side of the slide, this picture shows predominantly a lower or lumbar deformity. Now, the lower spine, of course, doesn't directly affect the thoracic cavity. However, a bad lumbar curve like this one, of course, this one is a different diagnosis, but the pelvis tends to come down and impinge on the ribs and can interfere with the diaphragm. And so indirectly, even these lower curves can have some impact on pulmonary function. But typically, thoracic curves will impact pulmonary function. Now, in patients with SMA, of course, you have to combine the weakness of the musculature, and that's compounded by any deformity of the chest wall. So any type of pulmonary function issues that we're speaking of in neuromuscular scoliosis, we have to think in many different levels. And that includes any intrinsic problems that may occur within the lung, any problems that may be due to weakness of the musculature that surrounds the chest wall, any problems that can occur because of alteration of the chest wall anatomy and the dynamics, and so on. So there's a lot to think about. So I don't know what happened with that, but that must have been a slide imported from another talk. But basically, a kyphosis. Okay, let me first describe this. This slide shows a patient with a lordosis. So this is arching backwards. Now, this is a different disease process, but I just wanted to illustrate the term lordosis. So this is a lordosis of the entire spine. A thoracic lordosis will actually result in narrowing of the front back diameter of the chest, which can definitely interfere with pulmonary function. But again, I have seen very infrequently this type of thing in the kids with SMA, although it can occur. So, what are the issues with the scoliosis, getting back to the themes of this talk? Well, obviously, there's a major impact on a progressive curve, has a major impact on sitting, positioning, and ease of care. There'll be a definite impact on pulmonary function, and this depends on the degree of curvature, the degree of chest wall deformity, which is an associated problem. And then obviously activities of daily living, if there's a challenge with positioning and ease of care, if one has to use one of your upper extremities to prevent your trunk from collapsing off to the side, then you're interfering with upper extremity function. So I think, as many of you well know, the progressive scoliosis can interfere with function at a number of different levels. So I'm just going to click through this, but I just put this slide to suggest to you that when we think about scoliosis, I kept mentioning early onset as, as opposed to late onset, which might be in teenage years, is that we're always thinking about the growth of the lungs and we're thinking about the growth in height of the chest cavity. And so ideally, you'd like to maximize the development of the lungs and the chest prior to having to do anything definitively for scoliosis. So for kids with early onset scoliosis, all this comes into play when discussing treatment options. Um, and so I guess one would say that patients with early onset scoliosis, again, 3, 4, 7 to 10 years of age, somewhere in there, we could state that, especially if it's neuromuscular early onset scoliosis, that this can be essentially a form of thoracic insufficiency syndrome, in which inability of the thorax to support normal respiration or lung growth. And so you can see from the lower left-hand side how a deformed chest wall can result in changes to the cavity and to pulmonary function. So here's a patient of mine, again, a different diagnosis, but just for the purpose of illustration, um, shows how here is the vertebra. So this is sort of like a slice through you, like a CT scan would have. I mean, it is an image from a CT scan. And you can see here that here's a vertebral body. Here's the heart all the way over here. And where's the lung over here, right? So this corresponds on the x-ray. Look at this side of the chest cavity and look at this side. So this is a 100-degree curvature, and you can see what's happening, not very positive. So I know that most of you are aware of all this. So let's think about treatment options that are available to us. Observation is certainly a treatment option for smaller curves, that especially if they're not progressive, especially in older patients, but even in many younger patients, as we're trying to work on strengthening and so on. I'll use the term positional curve control. That's an option for many patients. That might include the use of a brace or a soft spinal orthosis, as you can see in the upper right-hand corner here. That's a very common strategy in patients with neuromuscular conditions to try and delay the progression of a spinal deformity. I don't think there's science to suggest that one can definitively change the natural history of an underlying spinal deformity, but certainly if we can improve positioning, ease of care, provide support, delay the progression of a curvature, and prevent the need for a surgical intervention, then an orthosis might be worth considering. And certainly we do consider them. For the purposes of completeness, adjustments can be made to a wheelchair, for example, to accommodate a spinal deformity in a patient perhaps who's not medically able to have a surgery for scoliosis. So that is, again, for the sake of completeness, I'm mentioning that. Now, when it comes to definitive treatment, In our center, we're so subspecialized now that we have an orthopedic early onset scoliosis treatment team. And so early onset, if let's just say that a spinal deformity in a patient with SMA or scoliosis is progressing and is interfering with function and ease of care, and we're very concerned about the impact on pulmonary function, but yet they're not at an age where definitive treatment would be ideal. There are treatments available, and I'll show you some pictures that are surgical that are called growth sparing. In other words, this is kind of like, I don't want to use the term of a car jack, but it's placed in the spine or in the back, and it allows for progressive lengthening with growth that allows one to control the progression of a deformity of the spine while allowing for maturation in the lungs and allowing for growth of the trunk. And there are two ways that that's been accomplished. And for today's talk, I'll just show you some pictures. And the later onset would, of course, be something called a spinal fusion, which would be a single-day definitive solution to stabilize a progressive curve to alter the natural history. So I show a picture of my partner, who many of you may be familiar with, Robert Campbell, who passed away in 2018, but was my partner for 9 years. He developed something called the vertebral expandable prosthetic titanium rib, or the VEPTOR. And that's one option available for early onset scoliosis that preserves growth. So here's an example. You can see the curvature. You'll note that nothing was addressed at the level of the spine. This device was placed between the pelvis and between the upper ribs, and it was distracted. Nowadays, they can do magnetic distractors on here to gradually distract with time. The alternative, and before the alternative, is that in some patients with SMA, at least traditionally, there was a deformity of the chest wall. As you can see here, as the ribs are drooping down, they called it a parasol deformity. And so one could modify this VEPTOR device to be able to attach to the ribs and expand the chest cage alongside correcting or controlling the curvature. So that was a viable option for some patients with the parasol deformity and the progressive scoliosis. There's also something called a growing rod, in which an attachment is made to the spine, shown here to the lower spine and to the top of the spine. Nothing is exposed of the spine in the middle, and these rods are then lengthened every 6 to 12 months or magnetically lengthened. Another option. And then the definitive thing, with 3 minutes left, is a definitive spine fusion, which is a single-day event. For most of the patients with neuromuscular scoliosis, that event or that stiffening goes from the top of the spine down to the pelvis. And the goal, of course, is to get the spine to fuse together so that the correction is maintained through the lifetime, both to prevent any progressive spinal deformity that would impact pulmonary function, also to improve positioning and ease of care. And so I think, with 1 minute left, I'll just go through the 3 minutes left. We'll try to go through the take-home messages again. And, I hope that this talk was appropriate, and I hope that there was something new in there for you, but I guess we'll hear in the question session. So take-home messages: that we're approaching everything. Our natural history of the disease is altered by treatment, so we need to rethink and take a fresh look on the care of the musculoskeletal system. So we're going to do that. Obviously, multidisciplinary care is the most critical thing. We spoke about proactive and reactive strategies for contractures, and preventing and treating contractures, I think, will be essential for many of the patients who are ambulatory in particular. The hip is an area of ongoing study. Now we have surveillance programs. Now for individualized care, we will discuss with selected patients, the possible proactive measure of doing the guided growth. and as in my opinion, as part of a shared decision-making model, since we don't have a lot of high-level science to support it. And with the spine, I think this is a challenging subject area, in particular for those patients who develop an early onset deformity. We start with often bracing, and then if that's unsuccessful, progress to one of the growth sparing strategies, and then uh, at the appropriate age, definitive spinal fusion for progressive curves. So anyhow, I'll just say thanks again for the opportunity to speak to you. I hope the subject matter was appropriate. And I didn't try to throw a lot of science in there because I think really the science is going to be created over the next couple of decades. And we should do shared decision making with our patients and our colleagues in a multidisciplinary setting. So um, I'll get out of that. Can you guys still see me?
Yes, thank you so much, Dr. Spiegel. That was great. And thank you for sharing those nice pictures of your family at the end.
Sure. I'm the
All
fourth in
right.
I'm the fourth in line in terms of decision making in the family.
That's funny. um, all right. Well, I want to be sure to do a quick Q&A session. We did have some questions submitted during the presentation, but if you have any last minute questions, feel free to type those in and we will address those as well. I'm going to jump right into it. So, what are your thoughts on hardware placement for broken tibula or tib fib in non-weight bearing power wheelchair user?
Well, I haven't had that circumstance. In my experience, my practice has typically been in patients who are non-ambulatory to do soft splints for fractures and to manage them non-operatively. There are some circumstances where we've been extremely aggressive, for example, in patients with Duchenne muscular dystrophy, for example, who were ambulatory and recognizing that they needed a solution where they could get upright almost immediately or they would lose function. And so again, in a shared decision-making model, we've used intramedullary fixation in selected circumstances. So I think it depends on the circumstances. In general, in my practice, um, I have used non-operative treatment strategies, but if a patient is ambulatory, I think strong consideration is given to fixation. If we can get suitable fixation for early ambulation to try and not to to avoid deconditioning and try to promote early weight bearing and early restitution of function.
Great. Thank you so much. Um, this next one says 50-year-old with hips dysplasia and worsening pain in the right side. Is there anything to do?
Well, I guess it depends if the hip is, I mean, by dysplasia, okay, so the hip might be partially out of place, which actually may have a worse natural history than if the hip is completely out of place. So if the hip was partially out of place, it would depend on the functional status of the patient. So if the patient would be ambulatory, even if they have a neuromuscular condition, I'm generalizing because a total joint replacement might be very appropriate to consider under certain circumstances, particularly if there was adequate motor power of the hip abductors. That might be, and particularly if a patient was ambulatory. If a patient was non-ambulatory, then it would depend. Numerous choices are available for dealing with that in terms of salvage. And I can't say for sure that I know what is done in the adult population because I only follow patients till they're in their 20s. But I'm sure some type of resection, arthroplasty might be considered in that circumstance. In other words, where the upper part of the femur was resected. Let me just say, in our experience in that subject area is mainly kids with high muscle tone with cerebral palsy who have dislocated, displaced hips, who get very painful, and they can get painful in their late teens and early 20s. And so for those, we discuss different options for care. And as I showed on that one slide, the most common approach that we have to in that population is to either resect the proximal part of the femur if the patient is non-ambulatory and just wants pain relief, or to realign the bone if they're in a stander or they do limited distance walking. So I don't know if that helps at all, but
No, it
yeah.
definitely, I think it, gives some insight, but we would always encourage people to talk to their own providers and, discuss the details of their own diagnosis. So if you are looking for a provider, I believe we listed the MDA Care Center Finder in the chat. So you're welcome to explore that and see what's closest to you. And also, if you need any resources or have any questions, we'll also share the information to contact the MDA Resource Center. You'll talk to a live person and they can help connect you with resources in your area. So I think that definitely provided some insight. So thank you so much. Our next question is, are there early signs of scoliosis, joint contractures, or hip dislocations that we should watch for?
I think that everything really depends on the progress of the patient with regard to strength and with regard to functioning. So naturally, if we develop adequate trunk control and strength and we're able to sit unsupported and or we're able to ambulate, that sort of development of the musculature will be, helpful in preventing, although we're always looking, and observing on clinical exam. It depends on activity level, again, it's same old things. I mean, if patients have weakness to the extent that they're spending very limited time in an upright ambulatory type position, then they're going to be prone to developing all these. What I'm seeing in the multidisciplinary clinic is actually quite fascinating because with the new onset treatments, basically what I'm seeing is that a lot of kids who are getting stronger early, participating in more activities, making more functional gains, and therefore I'm wondering if I'm in the correct clinic. So a lot of the problems that we would expect to see and typically would see, we're not developing. So I think all of us do the best we can. I mean, you want to try to incorporate things that maintain range of motion as best we can, and recognizing that it's a tough enemy to fight, particularly when the kids are weak and you have the early development of the contractures. And so I would guess that the more activities that one's participating in, particularly upright mobility, will be helpful. Working on home stretching and the therapies under select circumstances, sleeping at night with types of splints or stretching devices, and so on. So I guess it's really, these are all secondary problems. So the hope, of course, is that with improving the primary problem that we're all treating, that these secondary problems won't be as onerous, won't be as likely to develop, and won't require as much treatment.
Yep, that makes sense. Thank you. Um, So we have another question from the chat. Is there a resource list of proactive stretches for SMA patients who use a power wheelchair, looking for stretches to help prevent contractures? I do want to mention that we do have an SMA at home PT exercise guide. It's a printable guide, and I will have my colleague put that in the chat. But Dr. Spiegel, if you have any resources that you're interested in pointing to, feel free to share.
Yeah, I'll apologize and thank you for adding that resource because I guess you get spoiled sometimes when you're in a multidisciplinary clinic most of the time, and that whole angle is handled by our therapist. So I have not been privy to what resources our therapists are giving to their patients. I could certainly find out for you though.
Yep, no, I think I would definitely direct to the MDA PT guide that is listed in the chat. So check that out. And if you have any additional questions, I would say reach out to the MDA Resource Center. Another question is, how often should imaging like x-rays be done to monitor the spine and joints?
The spine, to me, I'll just give you my own personal take on it because others may disagree. I don't feel that any earlier proactive bracing treatment can alter the natural history of the scoliosis and neuromuscular diseases, or at least has never been proven. I also find that kids who don't have good trunk control, or kids may have, a, shall we say, a postural abnormality of the spine, if we get repeat x-rays on them, they always look like they have some scoliosis. And the question is it a truly progressive scoliosis, or is it simply reflective of positioning or that type of thing? So my practice is to examine the patients, and if I feel like there's something that's progressive or structural or something that families are noticing, yeah, then we get an x-ray. But I'm sure around the country, there are some clinics that routinely get spine x-rays, others that don't. I just feel like, the kids get a lot of x-rays through their lifetime, and any way that we can minimize the use of x-rays would probably be a good idea. Um, but also, I've seen kids with a 40-degree curve on x-ray that six months later had a 20-degree curve. And so it wasn't actually a scoliosis, it was a postural deformity. Um, for the joints, no, but I do think it is worth doing surveillance on the hips. I just don't have um, exact recommendations other than to say that what we've adopted is we reviewed the guidelines, as I had mentioned, for surveillance in the cerebral palsy population, and we've adapted them, not exactly, but we've just as a multidisciplinary clinic decided that this is kind of what we're going to do.